Hello, dear One Health friends, and good afternoon to all of you. I would like someone from my team to show me their face so that I can make sure that you can hear me well and that, yes, okay. Thank you, Sarah. So it's a pleasure to be back with you to and update you in, I would say, a rather summarized way, but we really try and keep together the things that we think are relevant for a community like the community at UF. I will start our update seminar as usual with a broad brush update on what is happening around the world.
So we can all hear it.
I would invite everyone to close their mic, and then together with the One Health team, we have put together some topical issues that we think should be addressed. And then we have Sonja Rasmussen. Hello, Sonja, and she will give us, she's very active in the US COVID environment, and she will give us an update on vaccines and also on some of the concerns that there are around side effects. So with this, I will start sharing my screen. And this is good. Can I see somebody nodding at me?
Yes. Good.
Yes, good. Okay, so thank you very much. And yes, we are quite a while into the pandemic. It's been a year and a half, and things have changed substantially. Many things have changed about our lives, about how we perceive certain threats, and how we address certain threats that concern our health. And suddenly we realize how totally interconnected we are, and how important it is that we actually find novel ways to address these very complex issues in the future. So just before this seminar, I had a talk with, we did a little a catch up with Sonja Rasmussen, and she mentioned that just recently there have been 600,000 deaths. We have hit that mark in the United States. And this is something I think that we should all reflect on. These are the global numbers that I think you can see yourself. We have 177 million cases with 3.8 million deaths. But we have administered about 2.5 billion doses of vaccine, which, if you think about it, and if you think about where we were just a year ago, is actually quite astonishing. And we know from how the pandemic is evolving that vaccination has actually been extremely successful in flattening the curve. If you see the number of cases that we had at the end of 2020 and over the winter period, and then the vaccination campaign started, you will see how the number of cases has dropped dramatically. And as of June 21st, in the United States, there have been over 318 million doses of vaccine administered, and 150 million people are fully vaccinated, which means that that it's not enough, because the United States has about 350 million people, and so we need to get that vaccine more and more into the population. So let me jump to the other side of the world. We have all been very concerned about what has been happening in India. We have all seen the images of the devastation that this infection has brought. And certainly India is has reduced the number of cases, but is still very high, up there with the big numbers. 299.8 million cases occurred in India. The population of India, of course, is very large, and it is possible that there is an underestimation, but it is still very big numbers. There have been spikes of mortality, with certain areas reporting 6,000 deaths in 24 hours. And there is a debate which is very close to our heart, and that I will pick up later on in my talk, about the accessibility of vaccines to developing countries, to low and middle income countries, but also within those countries, I would say, the accessibility of vaccines to women. We have, so South America is having a very hard time with this pandemic. Unfortunately, and for reasons that are beyond my understanding, what is happening in South America has not really been advertised very much. And we know that there are some countries that are experiencing tragedies, and I'm sure that a lot of you have students and have who have their families in some of these countries like Uruguay, Argentina, Brazil, Colombia, and Peru. The death rates are increasing dramatically, and of course also in Venezuela. So South America is being hit very hard, and I think unfortunately this infection will have some long-term and profound ramifications in this part of the world. Okay, in Europe, and as you know, Europe was hit just after China. Italy was actually the first European country that was hit by the pandemic. Things are improving. So vaccine is being deployed. The vaccination programs have ramped up, because this was, of course, one of the biggest problems at the start. And many countries are ready for reopening. I would like to point out that in Europe, in many European countries, we still have to wear a mask, even outside. And but these bans, it looks like each country is moving a bit at a different pace, but it looks like they will be lifted over the next few weeks. And actually something which is, I mean, a success which comes with this story is that we have developed in Europe a digital pass. So there is a record of European citizens that have been vaccinated, so that European citizens can move freely across the European Union, because of course the European Union is many different countries, and it's not like the United States, it's just one big country. So this was actually something that is extremely important for many reasons, including the recovery of internal European movements for tourism. Among the topical issues, and of course Sonja Rasmussen will talk about the situation in the United States, one of the topical issues that we wanted to touch is the origin of SARS-CoV-2, because I'm sure that all of you have been really shocked or baffled by the fact that there has been an investigation, an additional investigation, which has been requested by President Biden, who has asked the intelligence community to figure out what has happened, come to a definitive conclusion in 90 days. And so I think that this needs to be explained a little bit. And so there's, let's say there are some, there's a polarized debate in which some leaders call to investigate Chinese laboratories because they believe that the coronavirus, which caused the pandemic, got loose out of a laboratory. So it leaked from a laboratory. But on the other hand, we don't have any evidence about that. And what we know is that this virus has a natural origin. And let me just explain to you what this is, what this means. So we know that the progenitor, the backbone, the progenitor of this virus comes from a bat virus, and the bat virus, through a series of intermediate steps, through the pangolin and maybe some other mammal, became transformed itself. There was a recombination and it became infectious for humans. And this is the what we believe, and the evidence we have points in this way. So this virus from a bat ended up in a live animal market. And in that live animal market, likely through the pangolin or another animal, it became infectious for humans, and it infected humans. So this is the natural virus. However, these natural viruses can be modified, and they can be used as a prototype to establish certain properties of viruses. And so some of the things that can be done are, for example, changing the genome of these viruses and transforming them, for example, in their receptors. And so this is work that has been going on for quite a while. And so just so that you understand, the laboratory leak hypothesis does not mean that this virus was a virus that was created in the lab. What it means is that a natural virus could have infected people either at the live animal market or inside a laboratory, because it happens that viruses leak out of laboratories. This has happened since we have had laboratories, and so unfortunately it happens. If the virus instead is a natural virus which has been modified, then the only hypothesis is that this virus became widespread through a leak which occurred in a laboratory, and we don't know. So we are waiting for this, for the results of this investigation. There's a very, very, I would say, dense discussion around this, because this type of work, which implies that you make viruses more efficient at doing certain things, like infecting people, infecting another species. These are called gain of function experiments, and are something that we are seriously going to have to think about as a scientific community. So what are the reasons that spurred this investigation? Well, there are several things that we don't know. We don't know if the virus was circulating when it started circulating with certainty, because there is evidence that from Europe that the virus was maybe arrived prior to November 2019. We still don't know if it originated from the live animal market. We don't know if there was any frozen material involved, because at one point there was frozen food that was believed to be the source of infection. And we don't have any evidence of viral circulation in animals before the pandemic. So there are certain pieces of the puzzle which are not really coming together. Okay, so let me move on to a short update on a few things that we think should be brought to your attention. First of all, the variants have changed names. And the reason why they have changed names is that, as you know, from the beginning of the pandemic, having a viral variant named after your country stigmatizes your country. And so after a year and a half in the pandemic, the variants have been renamed, and they have been renamed like the hurricanes actually this year, with the Greek alphabet letters. So the UK, British, English variant, British variant is the Alpha variant, and the so-called Indian variant, which is the one which is concerning, is most concerning in Europe, is known as the Delta variant. Now, one of the questions that we still don't have answers to is how long immunity lasts. There is evidence, though, let's say that the evidence points towards the fact that immunity, especially if generated by the vaccine, is not going to disappear in a season. And this is very good, which does not mean that we will not have to get vaccinated in the future, and does not mean that we will not have to update our vaccines like we do with influenza every year, that new variants are put in the vaccine itself. One of the things that the center with its collaborators have been involved in is understanding certain aspects of vaccine distribution, particularly with reference to equity. And so these are the numbers of COVID vaccines that have been given globally. And you can see the numbers yourself, 12% of the world's population. Which is not a very big number, but it is an incredible effort if you think that 6 months ago we didn't even have a vaccine. There is, of course, a concern that certain countries are not catching up, do not have accessibility to vaccines, and cannot reach the vaccination goal. And you will see from this table, and thank you, Costanza, for putting it together, that like the population, the US population, 3.28 million, 51% are vaccinated. But if you go to Africa, it's 2.2 that are vaccinated. Or so, of course, Europe and the USA and Australia are leading, but Africa and Asia are behind, and this is a problem because, of course, the virus can mutate, can evolve, can become a variant, and the more it circulates, the greater the chance there is that variants emerge. So going back to equity, which is, I think, that is something very close at UF's heart. The world cannot afford to not vaccinate everyone. And one of the big problems that we have is that we still have to use the cold chain to deliver our vaccines and store our vaccines. And so if you think about what a bottleneck this may represent, it is clear that this could be an enormous opportunity to actually start working on vaccines that do not require refrigeration, because of course a significant part of the world does not have access to continuous electricity, and therefore does not have access to refrigeration. And so a lot of the UF community works with developing countries, and this is how vaccines travel in developing countries, both for people and for animals. And so the One Health Center with its collaborators is looking into understanding what the impact of the cold chain is on the efficacy of vaccination programs. And this study shows that a significant amount of low and middle resource income countries do not have good enough infrastructure to store their vaccines. And so you will see that there are some that have old devices, some that don't even have the devices, some have broken devices. And therefore, this is something that I think should be one of the themes that we should address in the future. Because if we could have vaccines that that can be stored at room temperature and that can be shipped in the mail, this, of course, would allow us to reach even the most remote parts of the world. And this would benefit the health of humans and, of course, of animals. I'm speaking to the vets out there. It would actually have an impact in reducing antimicrobial resistance, because the WHO recommends the use of vaccines to avoid secondary bacterial infections, which we know are one of the causes of antimicrobial resistance. And if we worked on this topic in, I would say, an efficient way, we could actually look at lowering significantly the burden of preventable diseases. Of course, getting rid of freezers and of refrigerators also reduces the carbon footprint of vaccination. And so as we seek new ideas to move forward the health of humans, animals, plants, and the environment, this could be a really wonderful opportunity, which is a very long-term goal. I mean, we're looking at something that really needs to be worked on, but it is certainly something that I think will find space in the future. I wanted to say a few words on mental health, but I put them at the end, I think. Yes, and so let me just update you on COVID and animals. There have been a whole number of species of animals that have been infected. We now know we do have a lot of experimental work that has been going on, and we know that poultry and pigs are experimentally not susceptible. Dogs are a little bit susceptible, but there are other species that we've mentioned, like cats, ferrets, minks, bats, hamsters, macaques, and by cats we mean big cats as well. They do get infected, and they can't transmit the virus. And the OIE website is very well updated on this. But still, there's a lot of work that needs to be done on animals, because it is important to understand what species are the ones that we need to look into, what could be reservoir species, and there are many questions that we need to answer and we need to address, including what is happening in mustelids, which are minks, basically, and ferrets. And actually, I wanted to point out that I read there was an article which mentioned that there is a registry for ferret owners. Ferrets are pets that are quite popular in Europe, and in order to monitor the disease in the species, because they do get in close proximity with people and they can get severely infected, they have set up a voluntary registry, which is certainly makes owners more responsible about their pets. Yeah, and I would like to close my talk by mentioning mental health issues. We work for a university. We work with lots of kids. We work with kids that are younger, the kids that are a bit more mature, kids that are trying to work on their PhD, on their dissertation, and it's very hard for them. And there's a very interesting article in the New York Times, which is really puts together all the potential ramifications of this event, of the pandemic event, with everything that has come with it, from lockdown to using screen time and all the rest that we know comes with it. And this is something that we are going to have to help our students with. And so I would like to invite all the participants to make sure that they use the UF resources that support students, but also that students feel free to come and speak to mentors and the older generation if they need any help, because we understand that this is really hard on you. And with this, I would like to thank you for your attention, and I will leave the floor to Sonja Rasmussen, my friend and colleague, and the floor is yours. Thank you, Sonja. We are looking forward to your talk.
Great. Thank you so much. Sorry, it took me a minute. I am going to be giving an update on COVID-19 in the United States, and I'm especially going to be focusing on yesterday's Advisory Committee on Immunization Practices meeting, because I know many of you have heard about that. I listened in on about 6 hours of meetings about myocarditis and pericarditis among young people who, especially males, who are getting the COVID-19 vaccine. So I'll be talking about that at the end, but at the beginning, I'm going to just go through to give you an update on where we're at in the United States. So first of all, Ilaria already showed these numbers. You can see how the numbers are really substantially coming down in the United States related to vaccination. And but I do want to talk about the variants, because I think we need to keep in mind that this is becoming a more transmissible disease than what we had before. And I'm really particularly concerned about the pockets in the United States, places where there's lower rates of vaccination. Places where there's high rates, I think we're going to be okay, but places with lower rates, these, especially the Delta variant, I think is going to be really a risk. So there's a new US government classification scheme for variants. There's variants of interest, variants of concern, and variants of high consequence. The variants of high consequence are ones that have clear evidence that prevention measures or medical countermeasures are not working. Most of what we'll be talking about today is variants of concern. So there are ones where there's evidence of increases in transmissibility or of more severe disease, but not saying that either the vaccine or primarily that the vaccines are not working on them. So right now, there aren't any variants that are classified as variants of high consequence. Really, the ones we'll be talking about are variants of concern. So I showed you this last time. You can see that this yellow, this alpha variant, we won't say it, but the UK variant is continuing to increase. But you can see we're starting to see more of this P1 variant, this one here. And this is the Delta variant, the deep purple, the 1.617.2, which you can see why they decided to go with alpha, beta, etc., because you can see that that's a long name. That's the one that emerged first in India. And you can see the latest data. This is from a couple weeks ago, June 5th. The latest data is this now is making up about 10% in the United States. And I will just want to show in the next slide that these rates really differ in different parts of the United States. And, you know, we're a big country and different areas have different levels of vaccination and thus different levels of the different variants. So here you can see how much the 117 makes the in the South, but we're starting to see some of that variant, the Delta variant from India here. And this, because of its increased transmissibility, is going to continue to increase in areas with low levels of vaccination. So as you'd expect, the rates of hospitalization are going down and the rates of deaths are going down. So this is all good news that the vaccines are working. So how are we doing with vaccination in the United States? And there was a time when people were really scrambling to get their vaccination, really working hard to get vaccinated. You can see the rates of vaccination going up and up and up from December until sometime about mid-April. And then since then, we're starting to see the effects of vaccine hesitancy. People are, a lot of people have already been vaccinated. The people that were dying to get vaccinated, that were waiting online with their finger hovered over the website as soon as they could get an appointment. But there are a lot of people that are less interested. And so the number of people that are getting COVID-19 vaccines on a daily basis is going down. And here, I thought this was helpful. This is from June 20th. And here you can see of the total population, so that includes kids, about 50% total population, 45% fully vaccinated, of people who are eligible for vaccination. So 12 years and up, it's 62.4. For people greater than 18, since the kids are only recently available for eligible, 65. And then you can see the people that are at the most likelihood of dying, 65 years and older, 87.3 are vaccinated. So I think this is good news. This is a paper that was in JAMA just this last week, I think. And you can see vaccine hesitancy that is defined as being unsure or somewhat or very unlikely to be vaccinated for COVID-19. That's gone in October of last year from about 47%. It's dropping down, so down to 35%. Still a lot of people that are concerned about getting vaccination, and trust in vaccination is going up. So I think this is all good news, but I think we have a long way to go. This is showing again the people who have more concerns. So the dark blue is people who, this is from the Kaiser Family Foundation. They have great information, and it's an ongoing survey, so you can see how the numbers are changing. They're saying the people who answered the survey that said they've already gotten it or they want to get it as soon as possible. But I think it's important to note that younger people are more reluctant to get it. You can see the older people, 50 to 64, 65 and older, are more likely. There is a difference by race. There is a pretty significant difference by political party, and then urban versus rural. And some of this is access. Of course, it's a little more difficult, as you heard from Dr. Capua earlier, that it's a little bit harder to get a vaccine that needs a specific cold chain to certain places that are rural. And so some of that might be access, and some of it may be more related to hesitancy. Here are people who say definitely not, I don't ever want it. And it's somewhat the opposite of this, but there are some people that are in the wait and see or only if required category. So again, you can see it differs by age of people that say definitely they won't get it. Again, significant difference by political party, differences by race, and then urban and rural. So again, this is just showing race, that all groups are going up, but Asians highest, then whites, then Hispanics, then blacks. So we have a long way to go there too. And then for those of you that are clinicians, I think this is really important. Percent who say they are likely to turn to each of the following. The people that they listen to the most about whether or not to get vaccinated is a doctor, nurse, or other healthcare provider. That's more than the CDC, more than family and friends, more than the state and local health department, pharmacist, or religious leader. So it really is important when you talk to your patients, when you talk to your parents of your patients, if you're a pediatrician like me, to recommend that that vaccination is the best way to protect them and their children from COVID-19. So I just wanted to show this because as we're moving forward with vaccines among kids, this is asking, are you going to get your child vaccinated? And this is for people with kids 12 to 17. You can see some people are saying my kid is already vaccinated. Some are saying I want to get it right away. there's a significant proportion, 21%, that say wait and see. But here you can see 34% are saying I'll only let my kid get it if it's required, or definitely not. And then looking for parents under the age of 12, you can see a similar thing. Actually, even more people saying no, I don't want my young kid to get it ever, is 26%. So I just wanted to show this because I hadn't seen this before. It's a little bit old. It's from February, but it's was a survey among scientists about what they think is going to happen to COVID-19 next. And it's interesting that most 60% think it's very likely that it's going to become endemic, and 29% likely. So very few people think it's going to go away anymore. And but people do think it's possible for it to be eliminated from some regions because of vaccination. So here you can see these are scientists that are believed to be experts, immunologists, infectious disease researchers, and virologists from 23 countries. So now I want to talk about vaccines in younger adolescents. And as you know, the emergency use authorization, the first emergency use authorization for adults was for the Pfizer-BioNTech vaccine. It was for 16 years and older, and that was December 11th. Then on May 10th, after that, the company started doing clinical trials in younger people, and their plan was to do 12 to 15 and then go down to younger age categories. On May 10th, the FDA approved the emergency use authorization to be expanded for that Pfizer-BioNTech vaccine to include adolescents 12 to 15 years. And then on May 12th, the CDC's Advisory Committee on Immunization Practices issued an interim recommendation for that age group. So that's when we started to be able to have kids vaccinated. So what about kids less than 12 years of age? Here you can see in March of 2021, the Pfizer-BioNTech began clinical trials to study safety in kids younger than 12, so 11 to 6 months of age, and they're doing it in 3 different age group categories. They are using different doses for the younger kids than is used for adults. The endpoints are safety and immunogenicity. They're assuming the vaccine efficacy is going to be able to be inferred based on the 16 to 25-year-old population. And they're going to include 4,500 kids, and this is where the clinical sites are. And so what they're saying right now is we hope to submit the vaccine for EUA to the FDA in the September-October timeframe for children 5 to 11 years, and soon after for 6 months to 5 years. So for those of you that are looking forward to having your child vaccinated, we're hoping to have data that shows that it's safe and provides immunogenicity, hopefully in the fall. So there's been a lot in the literature recently, especially in the popular press, about should kids even get vaccinated against COVID-19. And kids are less severely affected of COVID-19, but that doesn't mean they're low risk, but they're not no risk. There certainly are children that have died, more than 400 children that have died of COVID-19, many children that have ended up in the hospital with COVID-19. And you can see I use that 20,000 to 100,000 because some people say, well, some of those kids are coming in the hospital for something else. And so this is the range that's being given. The other thing is, as I've talked to this group before, some kids develop multisystem inflammatory syndrome in children, or MISC, and that is a very severe illness that is a few weeks, 2 to 4 weeks after the child recovers from COVID-19. Some of the kids actually never even had symptoms of COVID-19, but they can have this post-COVID-19 syndrome that can land them in the ICU and can cause death. And then kids can also get long COVID. And actually the data seem to differ from different studies, but some studies show, and that should be 45 days, not 456 days. Sorry, I was typing fast. But there are a significant proportion of kids that end up having post-acute sequela of COVID-19. PASC is the new name for long COVID, and that's symptoms lasting longer than 45 days. So what about vaccines and myocarditis? And this was first, at least my understanding, the first it was noted in Israel. There was 148 cases of myocarditis, mostly among males, usually after the second dose. As you probably know, Israel has had a very successful vaccination program. And so a lot of people were vaccinated. Most of those boys that had myocarditis did require hospitalization, but 95% were considered to be mild cases. And Israel determined a possible link between the second vaccine dose and onset of myocarditis among young men ages 16 to 30. And this is their bottom line. They felt that the risks for complications of coronavirus disease outweigh the risks posed by the vaccine side effects. And they also stated that cases among teenagers aged 16 to 19 occurred in low rates and in most cases passed with no complications. So this is in the United States. Beginning in April, there started to be some older kids, not that 12 to 15 because it wasn't available for that group yet. It was in adolescents and young adults, 16 years or older, often occurred again after the second dose, typically within just a few days after vaccination. And CDC has been investigating it since those reports first came out. Again, most of the patients rapidly responded to medications and symptoms resolved. So what is myocarditis and pericarditis? I saw some cardiologists on the call, so I'm not a cardiologist, so you can correct me when I'm done. But myocarditis is inflammation of the heart muscle. This is a picture of the heart here that I snitched from Wikipedia. And you can see if you've done basically a cut here into the heart, this is the heart muscle, and then the pericardium is the sac around the heart. Here you can see there's the pericardium. And so myocarditis is inflammation of this part of the heart. Pericarditis is inflammation of that part of the heart. So features of myocarditis in children not associated with COVID-19. It also has a male predominance. The length of stay in the hospital is about 6 days. It's pretty rare, 0.8 per 100,000, but it does occur, and it is higher in this age group of 15 to 18 years of age. Causes can include infectious agents, most often viruses, toxins, immunological syndromes, etc. Treatment, a lot of kids just need supportive care, but it can go as severely as someone needing a heart transplant. The role of anti-inflammatory medications is unclear, and some cardiologists recommend exercise restriction while the heart recovers. So these 3 papers are in the literature, 2 in the journal Circulation and 1 in the journal Pediatrics. These all describe small groups of cases, mostly males, mostly less than 30 years old, and mostly within just a few days of that second dose of an mRNA vaccine. I think there was one case that was I think it was the Marshall paper that had a Rosner paper that had a Johnson & Johnson vaccine, but the vast majority of these are mRNA vaccines, the Pfizer or Moderna. Of course, we don't have any long-term data because we haven't been able to follow people very long, but the early data on acute outcomes have been good. So CDC has put together working case definition for acute myocarditis. If someone sees cases of potential myocarditis or pericarditis after a COVID-19 vaccine, it is required to report that case to the vaccine adverse event reporting system. And so if you're concerned about a possible case that you've seen, it's really important to report that case to VAERS. It's VAERS, and it's really easy to find online. The next few slides, I just want to comment, I have taken them directly from the CDC slides yesterday. This one is from Tom Shimabukuro's presentation, and it talks about what CDC is using as its working case definition for myocarditis. So chest pain, pressure, discomfort, shortness of breath, palpitations, and syncope. They need to have one or more of these symptoms, or different if the child is younger, or histopathological confirmation of myocarditis, or elevated cardiac troponin levels and cardiac MRI, and no other identifiable cause. There's also a specific definition for probable case. And here's for the acute pericarditis, the CDC working case definition. So when you do a field investigation, something like this, it's really important to have a definition that you can use. when you're reviewing the medical records. And this is 2 or more of the following features: chest pain, pericardial rub, which is something you can hear on with your stethoscope, a change in your EKG, and then a pericardial effusion. That's fluid in the pericardium, that pericardial sac that I showed you on echocardiogram or MRI. So here are the numbers, and so this is the numbers. These are preliminary still. This is what was reported to the Vaccine Adverse Event Reporting System. As a reminder, this is something that there's no denominator. It just anyone, patient, neighbor, anybody can, a clinician, anybody can report to VAERS. Clinicians are required for an EUA vaccine to report to VAERS. So here you can see both from Pfizer and Moderna, so both the mRNA vaccines, more cases after the second dose, 827 after the second dose than after the first dose. And these are of preliminary reports for myocarditis and pericarditis. So these are the characteristics. Again, this is another one of Tom's slides, not my slide. You can see the average age after dose 2 is 24. It's pretty quick after the time of getting the vaccine. Time to symptom onset is median of 3 days with 0 to 98. Sex more often in boys than in girls. So these are the symptoms that people come in with: chest pain, shortness of breath, changes on their EKG, elevated cardiac enzymes, and then an abnormal echo or MRI. And here is, they have been getting medical records on all of these cases and looking carefully through. They had 484 total preliminary reports. There are 148 that are still under review, and 323 met that CDC working case definition of myocarditis or pericarditis. This is just looking at how those kids did, or the kids are sometimes adolescents. It's anybody less than 29 years of age, 29 or less. 200 of the 309 that were hospitalized, 295 were discharged, and about 80% of them had recovered from symptoms at the time of the report. 9 were still hospitalized, 2 were in an ICU, and 5, there wasn't outcome data yet available, and 14 didn't need hospitalization. Here's some more data. This is looking at the observed versus the expected. So this is the number of cases that are observed versus the number of cases that are expected. And this is what led I'm sure all of you have heard on the news, that the Advisory Committee on Immunization Practices that gives advice to CDC did say that it's likely that myocarditis and pericarditis is linked. So they're saying this is likely the cause of myocarditis and pericarditis in these patients. They don't understand the mechanism very well at this point because it's so quick. It's something sometimes, 1 or 2 days after the vaccine. So you can see the expected for example, in the 12 to 17-year-old age group would be 1 to 12. There's 132 kids. 18 to 24, expected is 2 to 25 and 233. So clearly the observed number in these categories is greater than the expected number. But of course, whenever you're looking at vaccinations, you're weighing that risk and benefit. What's the risk of if you get COVID-19? What's the risk of disease with that versus with the vaccine? So these are rates per million doses. And this is the number that they're giving from the Vaccine Safety Data Link, which is a series of centers that are funded by CDC to look for vaccine safety signals. Here you can see about 12.6 per million doses of vaccine. That's a rate of seeing myocarditis or pericarditis. Here you can see that clearly the rate, that was for males and females. This is a rate, males is clearly higher than females, 32 per million doses in males versus about 5 in females. And this just shows, this is from another one of the presentations from yesterday from Grace Lee and Hopkins. They're the on the Vaccine Safety Technical Work Group of ACIP. They stated that it is notably higher after dose 2 and in males, the risk of myocarditis and pericarditis in adolescents and young adults. And these are the different rates depending on whether you're looking at chart confirmed or if you're looking at ICD-10. So you can see that number again I showed you on the previous slide, 32 per million doses of vaccine, or 4.7 after dose 1 in males. You see again, the rates in females are much lower. So then in the meeting, they carefully went through a modeling exercise where they showed what would be the risk of a child being hospitalized or dying of COVID-19 based on the current levels of COVID-19 in the United States. So it's not based on the way it was in December, it's based on the current rates of COVID-19 in the United States. And here you can see the benefits and risks after dose 2 by age group. You can see this is the risk of cases of myocarditis, and this is the COVID-19 associated hospitalizations that are prevented. This is for every 1 million doses of mRNA vaccine given. So really trying to weigh that risks versus benefits of myocarditis versus what would happen if you don't get the COVID-19 vaccine. So they did divide this into 12 to 17, 18 to 24, and then 24 to 29. So you can see, for example, for males, you would prevent 5,700 COVID-19 cases, but a lot of those are pretty mild. 215 hospitalizations, 71 ICU admissions, and 2 deaths. And the risk of that's the benefit of the vaccine. This is the risk of the vaccine is 56 to 69 cases of myocarditis. Here you can see in the ranges of 18 to 24 years. So similarly, more cases of COVID-19 because they're more frequent in 18 to 24-year-olds and more likely to be hospitalized, to have ICU admissions and deaths. And again, comparing it to the risk of the vaccine versus the benefit, 45 to 56 myocarditis cases. And then this is for the males, 24 to 29. So additional considerations. This took into account primarily the immediate effects of COVID-19. It wasn't taking into account things like the multi-system inflammatory syndrome in childhood, MIS-C. It wasn't taking into account prevention of the long COVID, and then also wasn't looking at the protection against variants. So the bottom line is that they said that this is an extremely rare side effect, only an exceedingly small number of people. And this came out yesterday. It was actually a joint statement. I received it as part of, as I'm a member of the American Academy of Pediatrics, but it came from several groups, including cardiology groups and Health and Human Services, et cetera. But what they said is this is a side effect of COVID-19 vaccine, but it's extremely rare. Exceedingly small number of people will get it. Those who do get it, the cases seem to be mild and recover on their own or with minimal treatment. We know that myocarditis and pericarditis are much more common if you get COVID-19, and the risks to your heart from COVID-19 infection can be severe. So the bottom line is they're still recommending vaccine for everybody 12 years and older, but and especially because of the Delta variant increasingly circulating. So I'm happy to answer any questions. They did provide some detailed information for people that might be clinicians and caring for patients who have it about whether you should get another dose or whether you've had pericarditis before COVID-19 vaccine, or myocarditis should you get COVID-19 vaccine. So, but I won't go into those details for this talk. So thanks. And we're both happy to answer questions.
Yes, thank you, Sonja Rasmussen, for your comprehensive presentation, which has, raised a lot of issues. So we don't have a lot of time. Sonia, maybe you want to pick up some of the questions because some of them relate to the vaccines, and then maybe I can pick up the rest.
Yeah, so what information do you have on the vaccine's effectiveness on transplant recipients? There's a lot of discussion about this, and there was some discussion yesterday in the meeting about this, that appears that some people who are on immunosuppressants after getting a transplant are not having, after the 2-dose vaccine, having an adequate immune response. And there has been some people that have recommended an additional dose of vaccine. I think right now that that has not been something that CDC or ACIP or FDA has made as a recommendation, but it is something that an individual clinician could recommend. One of the complications of that is that we don't have good information on what are the correlates of immunity. We don't know what level of antibody do you need to protect yourself from COVID-19. Remember, we really haven't even known about this virus for more than a year and a half. So we don't have some of those answers that we need to know about how long. So the other question, this relates to that too. What is the best estimate of how long is the immunity after Moderna vaccine? That was the other part of the discussion yesterday, is when are we going to need boosters? And the answer was, we don't know. We really don't know. What is the research on vaccine antibodies? There does appear there, we just finished up a paper last week, and so I just reviewed this. There is evidence actually of both women who get the vaccine during pregnancy that they pass the antibodies, they pass antibodies to the baby. So we don't know if those are going to protect the baby, but there are definitely antibodies in the baby after the mom gets vaccinated. Similarly, there are antibodies in breast milk. Whether those are protective or not, we don't have those data yet, but we do have information that they do pass. So regarding the length of immunity, we're going to be following, we now have some people who receive the vaccine, as I think the first dosing of the vaccine was late July in the clinical trials. And so we're starting to have people that are getting to a year. So they're going to be able to follow those people and see antibody levels and whether those people are getting sick. So I have not seen any guidelines about limiting exertion following the vaccine. They did not discuss that yesterday that I heard. I don't know anything about the Russian vaccine or the Chinese one. Do you, Valeria? I haven't
not
seen
a
data
lot.
on
Not enough that makes sense. What I did want to mention is one about vaccines, is the raising concern about antibodies. So some of the vaccines, there's a subset of the vaccines that have an adenovirus, which is a vector of the let's say the glycoprotein, and basically there is some, because in Europe a lot of AstraZeneca vaccine, which is made with it's similar to the Johnson vaccine, has been used. There is concern that the population has developed antibodies against the vector. So after 2 shots of AstraZeneca in this case, there would be antibodies developing for the vector that would make the 3rd dose, so what Sonia Rasmussen was talking about, so let's say an additional shot, the 3rd shot, there could be issues with the vector being unable to deliver the instructions. So this is one of the things that is, and actually another thing which we didn't mention because it would be so much to talk about, is that in Europe, because there have been cases of thrombosis in young women, there's been a lot of concern about the vector vaccines. And basically, some countries have recommended using an mRNA vaccine as a booster after you've been primed with an adenovirus. And so there is a lot of, I would say, people are disoriented because they understand that something like this has not been has not been tested. It hasn't been included in any clinical trial. But because of the concerns, there have been, particularly in young women, getting the AstraZeneca vaccine. This is what some countries are recommending. And so it is a very difficult situation because we need to manage the situation with what we have in terms of vaccine availability, but also with vaccine hesitancy, which in this case is being caused by overreaction to very, very sporadic cases of thrombosis, or, as you say, of myocarditis. Well, maybe this is a subject for the next meeting. So yeah, thank you very much. There were lots of us today, and Sonia Rasmussen and I will be happy to do another one of these, maybe around mid-August or the end of August, because we really think that it's important that we bring in different perspectives around this issue, which touches each one of us and each one of our families and our lives. So yeah, thank you very much for being with us, and we will let you know when our next update seminar will be. And for those who haven't had their vacations, have a nice summer vacation, and remember to stay safe and get your second dose, right? Sonia, do you have any advice?
If you're not vaccinated, get vaccinated. If you don't want to get vaccinated, then I would recommend you continue physical distancing and wearing a mask. Somebody asked that in a private note. I think that's the recommendation right now. Certainly COVID-19 is still out there in Florida and other places. So I think that's the best way to keep ourselves safe. So.
Yes. Well, thank you very much. Thank you to the whole One Health team, and stay safe. And yeah, thanks for your participation. It's important for us.